Right, we'll start, and might not say 9:30, but my phone does. That's what I'm going by. Welcome to our formal board meeting. Those members of the public who don't know me, I'm Piers Butler. I'm chair of the ICB. This is our formal board meeting, which is a meeting in public, not a public meeting. Number of agenda items. We'll try and move on as quickly as we can. Apologies for absence. I've got Damien Allen, Leslie Darbell, Richard Parker. I know that Kevin Turner, one of my non-execs, is on the way. He's stuck in traffic, I think. We're okay for chorus, I assume, Mark, looking at the number of people here. Yeah. Declarations of interest. Are there any declarations of interest over and above normal ones? Grand. Thank you. Minutes of the last meeting. Any changes or queries on them? Grand. Anything on the action log? Do you want to pick something up?
So it's action 6675, and it's in relation to the non-emergency PTS eligibility, and the paper was presented to the last quickly, and we received some feedback, and we are scheduled to go to JOSC at the end of this month. So I believe that action's completed.
Okay, brilliant. Thank you. Nothing else on the action log. Storytelling. A slightly puffed Katie who got the wrong venue and has run across Sheffield. How are you, Greg? I just thought that's what you would normally arrive like, Greg, you know. Yeah. Katie, do you want to do the introductions? And Jodie, nice to see you.
Yeah, very brief introduction from me today. So when I very first started doing board stories, Jodie came to present, and I think I contacted her straight afterwards and said, that sounds like it's going to be a future board story. So then got in touch with her, and fortuitously, she's just been working with comms to do some videos for Expo. So I'm going to pass over to Jodie, let her tell you about Bump, Birth and Beyond, and then we're going to see the case studies of the videos that were showed at Expo as well.
Brilliant. Jodie, welcome.
Thank you. I'm going to put the slides up. I've got a couple of slides that are just introductions really to the Bump, Birth and Beyond service. So this service exists really to increase access to existing services. It supports pregnant women and families in the most deprived communities in South Yorkshire, works with families to engage with healthcare and to identify and fill any gaps in services. Just move on. Intervention and support packages are designed with the woman and the family to meet their individual goals. So support might be one-to-one, it might be group work, might be signposting, advice and guidance, or it might be a mixture of all of those things. To date, so the service has been operational since February 2024. Some of the families the service has supported include young mums, families who've had previous children removed from care, families who are new arrivals into the UK and are unaware of the services that are available to them, for example. So the peer connectors support families with the social challenges that are worrying and important to them, which allows midwives and maternity workers to focus solely on the woman and her pregnancy, reassured that she's receiving the right support for the things that's important to her. We just move on. So to date, the service has supported 159 families across South Yorkshire. We know that we're reaching the families that we intended to reach, so 100% of the referrals are families in the most deprived areas. 50% of the families are from an ethnic minority background, and a large proportion of the mums using the service were 20 or younger. Next slide, please. And then just a little bit of context in terms of the sorts of interventions that the service is delivering. So lots of work around navigating services that's beyond health, really, housing, immigration, benefits, things that are important to families. Lots of support that's maternity related, so accessing appointments, accessing baby basics, things like that, safeguarding and parenting and family relationships as well. So that's just a little bit of background so that the kind of service offer is clear. So I'm going to just introduce two families now that have used the services, and then they'll tell you what it's meant to them. So if you just move on, please. So our first case study is Paige and Jantina. So Paige and Jantina are both deaf. They have a son who isn't. They were initially referred to Bump, Birth and Beyond when he was 6 months old, and the issue that were referred for was around housing and accessing benefits. When the peer connectors met with them, they discovered that they were users of British Sign Language. They could not read or write English, and they'd been missing their appointments for this reason. They were flagged by services as persistent non-engagers. So they were behind on their rent and their bill payment, They'd been referred to social care with claims of neglect, which had made them fearful of professionals and services, and they didn't engage with their local community and they were isolated. When the peer connector first visited the family, they could hear the television from outside of the house because Paige and Jantina couldn't hear it and had no idea what volume the TV should be on for the baby. The peer connectors have used BSL interpreters from the first visit. They've taken time to understand the barriers and challenges that the family faced in accessing services. They've helped them to communicate with other professionals and services, advocating for the family. And so on the next slide, Paige and Jantina will tell us.
Okay, do you want to say anything, Paige? Yeah.
Faye's been really fantastic. She's a fantastic person. You know, if we hadn't had any input, it would have been a struggle. You know, because I would have been really concerned and I would have been starting to feel really low. But thank God we've had the support. Sorting out helping everything with the house and with our debts and our bills, and because it is so difficult with the communication barriers as a deaf person. But I felt we've had so much support throughout the whole process. Helping book appointments and helping us get everything that we needed for us and our child really. Because before the support we've received from other teams and people, we always felt fallen a bit short and we've been ignored. So that's why the support we've had from this service, I've always felt that Faye and everyone has had our backs and they've been really involved and been there the whole time. But everything that we've done, it's been so lovely, and the activities and things as well, and getting together with everybody has been great. And at Christmas, with the party, that was lovely for everyone to get together and for all the children to mix as well. It's been a really great, impactful experience. It's been really, really useful. And that's it. Yeah, so thank you so much to Faye and everyone.
Thank you so much, guys. I feel a bit emotional. Oh.
So that's Paige and Jantina. So since they've been accessing support, we have discovered the referrals to social care were unfounded. They were based on misconceptions and a lack of understanding about their communication needs by professionals. They now attend Makaton, sing and sign groups in the local community. It's really clear that their confidence has grown in terms of life in general, but their parenting. They've been supported to resolve their housing and the financial challenges, which has removed a huge amount of worry and anxiety for the family. And they now know which volume on the TV is appropriate as well, which is great. So we've got one more video. So the next video is going to be David. If you just pause for a second. So based on feedback from local dads, so the point of this service really is that it's responsive to local need. And dads told us that actually they didn't have much support in terms of becoming dads. They'd often not got good role models in their lives. They didn't have a safe space to talk through their issues, challenges and worries. And so as part of this, we also developed a dads group. So the next video is David's story, and David will tell us what that means, with thanks to comms colleagues for making this one lovely and glossy.
I was contacted about Barnardo's delivering their Bump Birth and Beyond project, with Mexborough being the chosen site for the project in Doncaster. In Doncaster, our community midwives also work out of our buildings. So for us, it was the perfect kind of scenario, really. Midwives in the building, pregnant women come into the building for their antenatal appointments, and then they would meet the early days worker. What we identified was with Barnardo's, they could offer a more targeted service to families, and they were able to directly offer support one-to-one to families, so go to a family home, help with a wide range of things, going to appointments with families, all kinds of things that we at the time, and probably still now, don't have capacity to be able to do.
David's children go to the Mexborough hub, the nursery there. So I came across David one day when he was bringing his little girl into nursery.
I met Debbie for the first time. I knew Jane before, but I met Debbie for the first time. And she introduced me, wanted to know if I fancied going to a group. It was a dad's group first off.
Jane, the 1001 early days work, because she introduced me to David. And from talking to David, and him struggling a bit with life in general, having his children back home, and his partner's got serious health conditions. So we talked about really how we could help.
Because Jane had told her the troubles that I'd had, and she said, come to our group, it's a men's group, come and have a chat with us. So we did, and it made an hell of a lot of difference. I feel I can confide. That's one thing with my life. I found it very, very hard to confide in people all my life. But Debbie and Jane, I can confide in both of them. And I think that's what it is. It's like secureness. Whatever we've got on our minds, they will listen. And they do sit and listen. They give me brilliant advice. Debbie and Jane do that, whereas a lot of other people didn't do that.
It was a slow process, coming and building the trust, because he has got a life story, and you're not going to come and talk to somebody straight away about what's affecting you. But by David coming week after week, really helped. I think I'm going to use this word, empower David, because not only was he coming and helping us run the dad's group, but he was coming and offering his own advice to other dads, and that's why it really went well.
You walk in on a Thursday morning, you can walk in and you've got a face, smiles, you've got joyful, you don't feel no hurt, I don't feel no hurt like I did. The whole point of the group, it just inspires me. There's been people and people and people coming that's had the same experience as me. I've spoke to them, and my experience has made a difference to them.
If I could have took a picture of David when I first met him to the picture of David now, I would say the difference is he feels self-worth, empowerment, knowing that he's got something that he can help other people with, and he does. And I think from that, that's improved his emotional well-being, which has had a better effect on his home life.
Since I've been going to that hub, and the things what that hub has done for me and Kirsty as a family is absolutely remarkable, and I don't even know how I'm going to be able to thank them.
Thank you for listening. So I think it's really clear from the videos the impact that it's had on individuals. I think to note, this is a pilot service, so it runs in 1 or 2 neighbourhoods in each of the places in South Yorkshire. It isn't broadly accessible yet. I think our evaluation will be really key to demonstrating that long-term broader impact, which we'll need to consider for future commissioning of services like this alongside core maternity services.
Katie, that was great. Jodie, that was great. Any questions or points from the board? Greg?
Oh, sorry, yeah. Great example of sort of high volume, low volume, high impact stuff. I agree with you. It's sort of how you build this into routine commissioning, because it helps with regard to inequality, et cetera, et cetera. And I don't know how that works, but I would kind of strongly endorse the approach.
It's perhaps worth reminding the board at this point that we're one of 3 ICBs that are working with Barnardo's around the sort of child health equity partnership. So there's Birmingham, Solihull, Cheshire and Merseyside and ourselves that have got extraordinary funding from Barnardo's that we need to thank them for doing this interventional work. So at the moment, all that child health equity partnership work's being evaluated around impact. So I'm now serving on the board of that child equity partnership, working with Nicola to try and do the evaluation of this work in terms of its importance. So it's the sort of thing that we really need to try and carve out funding for, to try and continue this sort of low volume but huge impact work. But it's the sort of work, to be brutally frank, that in the current funding environment, it's really hard to find the wriggle room to fund. So I just wanted to put on record thanking Barnardo's for their funding support and how important the evaluation of this work now is.
Shafiq?
I think it just reminds us, doesn't it, that actually it is important in terms of medical and clinical services, but actually for that whole patient approach, we've got to have a look at what else we can do to support those people in the community. And time and time again through the storytelling, we see that actually voluntary community sector organisations and work in the community is actually really important for people.
Thanks, Piers. I mean, in my briefing later, I was going to mention the 4th annual Children and Young People's Alliance conference earlier this month, and we heard from Birth Bump and Beyond as part of that, but also, a range of other initiatives across the system. I think what was particularly terrific, I think, at that event was just to hear young people themselves talking about the support that they had received. And I think a bit similar to Lee. I mean, what struck me though, from all of those examples, and obviously, David and Paige and Jantina and their little boy today, is how relatively small inputs particularly from voluntary organisations, makes a massive difference. So I think Lee's point about, just to put it into hard financial kind of language, the return on investment is enormous. So I think it's just great to see those examples. And I will talk a little bit about financial challenges and all of that later, as you might expect. But I think we must not lose sight of not only the human impact and value of this work, but also the economic value as well.
Catherine?
Yeah, thank you. I mean, I'm really proud of this project and being able to work with Jodie and Nicola from a children and young people's perspective. And I think when we set out on this, but also the other work we're doing in the maternity and the CYP space, that formal evaluation bit has been the conversation we've had from the beginning for those very reasons that you've articulated, Lee, because actually, why is this different to other, similar projects? And I think for me, we hear from the kind of key workers and the leads very regularly through our local maternity and neonatal partnership board, and actually the impact in being able to families who've had previous children removed, but enabling them to do this differently with the proper support and actually have children back into the space is just so it's much broader than just kind of that maternity and CYP space. It's got huge benefits, and I really look forward to seeing the evaluation as we move forward.
Lisa?
Thank you so much for presenting that. That is just excellent. I think going back back to what Gavin said, it's just investing in someone when they're that young enables them to become full functioning adults. It improves their mental health, it improves their health in general, they're less risk of diabetes, it's kind of that left shift that we always talk about, and that prevention. So it's just so necessary, and it's great work. Thank you.
Thank you, really helpful. Just one thing I'd say to the board, we are going to have to make some of these decisions as we get the evaluation. One of the things I think we've not got right as the NHS, and this kind of scheme is going to force it to us, and as a commissioning organisation, is we've tended to say, can I establish this everywhere? When the right answer might be, we just put it in the areas most need. If we're going to tackle health inequality, it's not about universal services, it's about targeting services and need, and increasingly, given our financial pressure and the need to make a difference, we are going to have to do that. And we're going to have to say to our public, we're putting that service in there because it's needed, but we're not putting it in your area, it doesn't need it. And we're going to have to not just defend that, but be quite proud of doing it. And it's not something the NHS has done brilliantly in the last few years. So just think that's worth thinking about going forward. Clearly, we need the evaluation. But great work, Jodie, lovely to see you again. Thank you. Katie, thank you. Worth making it. Okay, Chair's Matters. I've just got a couple of things. I was about to say you probably know, but you've probably read most of it, heard most of it. The NHS plan, we are told, is the 10-year plan's being formally released tomorrow. You will have seen a lot of stuff about it. The one thing I would say, and I had quite a full briefing on it yesterday, is there's a danger that in the context of what the ICB is going to look like, that we are getting very depressed about the ICB, about the staff reductions, which I'll come on to in a minute. But there is something here about if this change in the NHS plan is going to happen, it will be ICBs as commissioning organisations are going to have to make it happen. And so I think there is a really important role for us over the next 5 years And I think that will be quite explicit in the NHS plan. Let me just add something else. We're talking in the private section of the board about the staff changes as a result of the ICB reductions. I think it's probably worth formally noting as well, a number of other organisations were announced as having major changes in the last couple of days. This is very stressful for our staff, and now for the staff of a wider range of groups. It's just worth noting that. This is a very difficult time. I know our staff are feeling it. I've spoken to some of them, but that is now being widened. People like Health Watch, the CSUs, and I just think we all need to know some of those staff are suffering. We're going to be suffering real difficulty over the next few years. That's all for me. Gavin, can I hand over to you for your chief exec's report?
I'm probably going to just cover a couple of those points. I mean, particularly the changes to the ICB. I think this is probably the first public meeting we've had where we'll be able to share a bit of detail about what that means for the ICB and our future role. And obviously we're at a critical point in that process. I was going to just touch a little bit on the government spending review, which has happened since the last time we met, and some of the highlights from that. Reference the national plan, the 10-year health plan, and pick up some of the kind of, I suppose, the business as usual challenges that we're facing within the ICB. And I perhaps just want, maybe if I start with that, and then I'll move on to the spending review, the plan, and then the ICB changes. So in terms of the financial plan for this year, I mean, as we've shared before, and Lee will give an update later in the meeting about, I guess, the detail of the progress and our financial position. But this is a challenging financial context. We agreed a plan across the system with our partners earlier in the year. I have to say that process was, I think, very collegiate. I think people have come together and worked well to develop our plan. But it's an ambitious plan. I mean, we've got an efficiency requirement across South Yorkshire of about £270 million, which is just under 7%. So that is a big requirement. Now, we are in the process of strengthening our arrangements across the system. We've got a kind of governance architecture, something called a system efficiency board, which brings together the leaders of the NHS organisations and the ICB. We've also got a system leadership executive, which is a slightly wider group with local authority membership and others. But they're the principal means by which we oversee the delivery of this plan. But in that context, we will be seeking to strengthen some of those arrangements because of the scale of the challenge and the risk associated with delivery. So at the end of month 2, and again, Lee will give a bit more detail, the system was marginally off plan. So we were, I think, 2.9 million off our plan, 2.1 within the foundation trusts and 0.8 within the ICB. Now, that's a relatively, I guess, modest variance in the grand scheme of things, but I think it is still a concern. And I think particularly in the context of the scale of the plan and the risks within the plan. So, I mean, basically, although it might seem like a relatively modest number in the grand scheme of things, I think we need to see it as significant. And consequently, we'll be having a conversation tomorrow evening with the foundation trusts, Liam, myself, and other colleagues, basically just around our response to that. But within the ICB itself, as part of that £270 million savings plan, we're required to deliver around £90 million worth of savings. So there's a significant ask for us as an organisation. And I think given the position of Ubuntu and the risks that we know that are inherent within that plan because of its scale, I think Pierce and I have agreed a number of measures to strengthen our internal response. So just to share with you, first of all, we want to establish an additional subcommittee of the board, effectively a turnaround committee to focus on the delivery of our transformation plans. That will be a non-executive committee, but obviously officers will support that, including myself and Lee and others. But I also want to strengthen our internal arrangements for the delivery of the plan. So this is delivering the programmes of work, each of which are led by executive directors. But I'm asking Sarah Perkins, particularly with other colleagues in support, to lead on the delivery of that programme of activity. So I just wanted to, I suppose, it's kind of early in the year with just reporting the 1-2 position, but just to say any movement off that plan ought to be a cause of concern, because the plan is extremely difficult to deliver. So I hope board colleagues will support those steps to strengthen our governance. So I kind of just wanted to give that heads up. Just on in terms of the spending review that took place back in June. I mean, you will have heard that the NHS fared relatively well, comparatively well, with regard to other parts of the public sector, other government departments. So we'll see a 3% in average real terms rise over the next 3 years. But I think it's worth saying that although that is welcome, and it is true the NHS has done better than other departments, that is still a really challenging environment. When you take into context demographic changes, advances in technology, NHS pay awards, etc., a 3% increase is somewhat less than the average that the NHS has seen over its history. It's somewhat more than we've seen over recent times, but I don't want people to have a sense that that means that the operating environment will be easy going forward, because I think it will continue to be significantly challenging. Just on the national plan, I mean, we've seen quite a bit of that trailed in the media. I'm kind of reluctant to comment on that. I mean, you know, we've heard comments on the health watch bodies, the freedom to speak up arrangements, the integrated care partnership, which obviously we've put a lot of energy into, and I think is delivering real value. So I kind of don't want to comment until I've seen the detail. You know, we've got the opportunity of some briefings with the Secretary of State over the next sort of 48 hours or so in advance of the launch of the 10-year plan on Thursday. So I think that's probably all I wanted to say on that. Just in terms of the changes for the ICB itself, I think I maybe gave a headline of this at our last public meeting, but on the 1st of April, Jim Mackey, who's the transitional chief executive of the NHS, wrote to NHS leaders, basically covering a couple of principal changes. One was the absorption of NHS England over the next 2 years into the Department of Health and Social Care. So you know, we're seeing that transition taking place. But closer to home, there was an announcement around the ICBs, and it had two aspects. One was a change in our role, and second was a change in our operating costs. So in terms of our role, today we act as a system convener, system leader. We have some oversight responsibility for NHS providers, and we're the Commissioner of NHS Services. What the direction of travel means is that we're now required to concentrate on that last part of our role specifically, so the commissioning responsibility. So there was a document published at the beginning of May called the Model ICB Blueprint, which sets out a future role for the ICB, which is principally in that space of strategic commissioning, with a leadership responsibility for improving population health. It doesn't change our statutory aims of improving health, tackling health inequalities, providing value, adding to the wider social and economic developments of South Yorkshire. So those statutory responsibilities remain, but we will achieve them through the medium of strategic commissioning. So that's a different role. It's in some ways it's a narrower role, but I think when we see the 10-year plan published, I think the importance of the ICB as a commissioner in command of £4 billion worth of public money to achieve those statutory aims will be writ large. I think the other thing that I'm really hoping to see in the plan is a focus on integrated neighbourhood healthcare. And one of the things that we've really championed as the ICB is the development of our place partnerships. Now, our contribution to those partnerships will change because we will become the commissioner as opposed to the convener. But nevertheless, those partnerships remain really important. And what I would like to see is those partnerships developing into structures that we as the commissioner could commission integrated neighbourhood health from. So I'm kind of looking forward to the publication of the 10-year plan, because I think there will be opportunities in there. Now, with a narrower role comes a reduction in our operating costs. So maybe just to explain what that means. So currently we have so our operating costs are around £60 million. So I'm not talking about the £4 billion we spend on NHS services. I'm talking about what it costs to run the organisation. A sort of a value per head of weighted population of £19 per head has been identified nationally, and that now determines the operating costs of the organisation. So if you do the calculation, our weighted capitation, our weighted population is about 1.6 million times £19. Comes out at around 30 million. So it's about half our current operating costs. So we'll need to reduce our operating costs from 60 million to about 30 million. Now, clearly that has a big impact on our people, because we're the sort of organisation that most of our costs are associated with people. So we will be reducing our workforce to reflect that. So at the end of May, we were required to submit a plan about how we would do that in broad terms, which was accepted. And since then, we've been working on the detail of what that means in terms of our organisational form and the people we employ. But in essence, we currently employ about 800 people. If we're reducing our costs by 50%, we expect to reduce our workforce by 50%. So that's down to about 400. I'm rounding for ease of kind of explanation, really, but there are vacancies to be taken into account, etc., etc. There are whole-time equivalents versus posts, but in essence, it's about 400 whole-time equivalents will come out of the structure. So we're in a process where we've been having weekly dialogue with our people as this process has developed. We're gearing up towards a consultation process with our people. I'm of a mind that I'm keen to start that process as soon as I possibly can, simply because this is a huge time of uncertainty. And I think we've got a responsibility to our people to try to give certainty as soon as we possibly can. And the first step in giving that certainty is to begin that formal consultation process, but it is subject to approval by the board. There are issues associated with that, like the cost of redundancies and how will they be met. And we are involved in conversations nationally and regionally with NHSE colleagues about that particular challenge. I think the final thing that I'd want to say in this context is, one, we're working really hard to support our people. This is a time of huge anxiety for colleagues. So we've got quite a well-established wellbeing offer already, but we're looking to try and augment that as best as we can. We've tried to be very active in terms of communicating with our colleagues, but also we tried to be really active in terms of communicating with the wider system and our partners. So that's political leaders, MPs, local authority leaders, NHS organisations, the voluntary sector. So we've been in I suppose a kind of communication mode for the last few months. But I suppose the final point that I'd want to make on that particular topic is just to say, that's a big change for us, but nevertheless, that role of Strategic Commissioner remains a really important one. And I think as the 10-year health plan lands this week, I think there will be huge opportunity for us to influence how those ambitions set out in the plan are delivered. So I think that's all I want to say on that. The final thing I just wanted to say is I was going to mention the Children and Young People's conference earlier this month. Earlier last month. We're in July. It was in mid-June. But just say what a fantastic event that was, and great to see so many young people involved. Thinking about next year, I mean, I know Ruth Brown, the Chief Exec of Sheffield Children's Hospital, is absolutely focused on the fact it's 150th year anniversary of that institution, which is obviously a really important part of how we care for children and young people in South Yorkshire. We also should see the opening of the National Centre for Child Healthcare Technology at the Olympic Legacy Park, a tremendous national asset, but terrific to see that here in South Yorkshire. So there'll be lots of, I think, celebration around young people next year, particularly. And I think the final thing I wanted to mention was the AUP campaign. So this is a text service 24/7 that's been launched across South Yorkshire. So it's called the AUP campaign because if you text AUP, that colloquial and well understood greeting in these parts to 85258, 24/7 you can access through the medium of text support if you are in crisis in terms of anxiety or other mental health issues. And you might think, well, that's a bit impersonal. But interestingly, research would suggest that actually people would prefer to access support through that medium than actually speak to somebody necessarily face to face in the first instance. So the fact it's available 24/7, you know, in the darkest hours, in a way that actually people, interestingly, may feel more able to access, I think is a really important step forward. So I just wanted to pick out those two things, ending on a bit of a positive, if I can.
Cheers. Thank you, Gavin. Any questions for Gavin? Thank you. Okay, questions from the public. Andy, am I handing over to you?
Yes, absolutely. Thanks, Piers. So we have a couple of questions from Nora Everett at the new Health and Social Care Party here in South Yorkshire. So mainly based on the announcements we saw in the media over the weekend. So I'll take the questions as a total and then give the response in full, if that's okay. So the first question was really about the announcement on the abolition of the Health Watch organisations, the Guardian's Office and the HSSI body, and how directors are going to ensure safety, quality and accountability of commissioning decisions. The second part is really about how those decisions are going to be informed by the real-time experience of patients, front carers and frontline staff. And then the final part of the question is really how will South Yorkshire ICB involve staff and service users as the current law requires, ensuring that they have a voice in the commissioning arrangements, and a wide range of ways to become involved in those. So really, the response is that we're aware of the information that was shared in the media over the weekend. We will await the publication of the forthcoming 10-year health plan, in line with the changing role of the ICB as a strategic commissioner. However, we remain committed to ensuring that decisions regarding health services in South Yorkshire are focused on safety, quality and accountability. NHS South Yorkshire, through its Start With People strategy, is committed to ensuring that patients, partners, carers and frontline staff continue to be able to reflect real-time experiences in our decision making. And then the final point is that the ICB is committed to ensuring that people in South Yorkshire are offered a variety of methods to engage with us and become involved in the development of commission services. And as I say, and as Gavin and his peers have alluded to, we'll await the publication of the 10-year health plan, and I'm sure we'll have much more to say on it in due course.
Thanks, Andy. And yeah, it's very difficult to actually comment on effectively leaks about bits of the 10-year plan, because that's effectively what this is about. So we're going to get a lot of information, I think, tomorrow afternoon on the 10-year plan, and that will take a lot of time for the whole of the NHS, not just us, to absorb. So it's difficult to do much more than what we've done. Andy, thank you. Board Assurance Framework, Corporate Risk Register. Mark.
Thanks, Chair. I'd like to take the papers as read and just bring you straight to the recommendation and then just add a bit of context.
Thank you.
So the board is asked to review and approve the BAP and the risk register that's presented. I would ask that the board note the ongoing change context that both our chair and chief executive have set out. So in terms of our operating context and the changes that the ICB is going through, and just to note that those changes you will begin to see those changes reflected in the content of the risk register as they're brought forward to future meetings of the board. So I'm happy to take any questions, Chair, but that's just an introduction to the paper.
Thank you. Any questions? I mean, I think it is very likely that our risk register alters significantly for the remainder of this year. And if you think about the new role, it will look totally different, I would imagine, from the 1st of April next year. We'll almost start rewriting it again. Mark, thank you. Moving on to the next agenda item 10, Maternity Neonatal System LMS Quality Equity Action Plan. Kathy, can I hand over to you?
Yeah, I'm just going to briefly introduce and then I'll hand over to Jodie so I don't steal her thunder. As part of our reporting to board around the local maternity neonatal system programme, we come twice a year, so we do an update on the national safety ambitions, which we did at the latter end of 2024, and then we do an update on our equity plan, and we're into year 3, so making some real good progress around that. I think it's quite helpful as being here today to present maternity, considering the announcements over the last 10 days around the sort of review of maternity safety nationally and what that's going to look like, which we're sort of still waiting further detail on that. But I think the equity plan and what Jodie will describe for me is the really important part of improving outcomes for women, birthing people, babies, and then children as they sort of progress, I think, in the way that Lisa's described. So really important part of work, and again, how we hook this into really strong strategic commissioning for outcomes as we move forward. So Jodie, I'll hand over to you.
Thank you. So the plan was published in 22-23. We presented an update to this board and published an update in 2024, which set out progress to date, and then the paper that you've got in your pack sets out that continued progress. So I think there's a couple of key things to highlight, really. So we've made progress as an ICB in terms of the things that we set out to commission. So we have new perinatal pelvic health services operational across South Yorkshire, maternal mental health services operational across South Yorkshire, new service developments like Bump Birth and Beyond that I've described already this morning, focusing on health inequalities. Across the system, we've made significant progress in terms of preventative measures. So smoking at the time of delivery is at an all-time low across all places in South Yorkshire, making progress in things like vaccinations for pregnant women, with more work to do around kind of targeting those communities and areas with low uptake. There's our providers are making progress in the kind of core maternity service offer. So the paper sets out a bit of detail around Saving Babies' Lives package of care, which includes 70 interventions. Our providers have implemented over 85% of those clinical interventions. In South Yorkshire, we're the only ICB where all providers have met all 10 safety actions within the clinical negligence scheme for trusts. So I think the point of adding that context really is that despite all of this and all of the work that's happening in the core maternity services, we are only marginally shifting outcomes. So those poor outcomes do still occur. Harm does still occur, avoidable harm, although it's very, very rare, it does still occur. And so I think the point really that we're trying to make is that, yes, we kind of learn from harm. Yes, we've got robust processes in place for listening to women and families, but actually, in order to continue to make these improvements, it's broader than that, those core maternity services and the health inequalities and the focus on that and the services that support families broader than that core maternity journey of 9 months is really important. So I think I kind of come back round to where I started before, which is that there are some real opportunities in strategic commissioning for us to think about that. Summary.
Jodie, thank you. Cassie, thank you. Any questions on maternity? Can I just ask on the national stuff, and I'll come on to you, Greg, sorry. There was talk of a deep dive into 10 trusts. We still don't know who they are?
No, we've not got that level of detail yet. There's a summit, not next week, the week after, for NHS chief execs and chairs, and we've got a chief nursing officers meeting the day before. So I imagine some of that will start to emerge out of that. I know Richard Parker from NSRO, from our perspective, has written to the national leads just to try and get some clarity and understanding, and also, I suppose, as we move into what the new organisation and ICB is, what is the role of LMNSs in the sort of new world, and we might get a bit more information on that with a 10-year health plan tomorrow. So I think that's still emerging. What has gone out to all of our providers from the national team is some letters around sort of assurance. So we're working across the system with providers to sort of pull some of that narrative together. That will go to our local maternity and neonatal board next month, isn't it, Jodie? But I think we're pretty assured with the work that's been done across our services and systems. And when you get into the IPR, whilst our stillbirth rate is certainly still not where we want it to be, we know from our PMRTs that actually there's some really core links to deprivation obesity, and again that sort of challenge with communities that find it more difficult to access some of the services and professionals that are there and offer support.
Cheers, Jodie. Dead Alpha report, really good example of system working, and agree with you 100% on the point with regard to more than just maternity services. Just in terms of what's there, I'd welcome a little bit more in the future as kind of equity in outcomes, kind of getting underneath the population metrics. But yeah, it's a sort of minor point. Just an observation, there's something I think we all need to consider around parity in outcomes. So SATOD matters to outcomes way more than people in trolleys outside A&E, being brutally blunt in terms of outcomes. And there's just something that the NHS needs to institutionally consider around that stuff. Ditto maybe breastfeeding. And obesity, I agree with you. We've done a really, really good job collectively on smoking at time of delivery. Obesity isn't going to be solved by pumping mums through weight management classes. It's going to be solved by population measures. From what I've seen, I don't think the 10-year plan will be particularly strong on that. But that if I had to ask ICBs to do anything, it's to be really pushy with government on robust population measures on obesity. We'll do what we can locally, but the big levers are national.
Great, thank you. Really helpful. Any other points? Grand. Jodie, thank you. Nice to see you again. Item 11, place partnership updates. Are we starting off with Sheffield, am I? Emma, yes?
Chair, yeah, because I'm incorporating some updates on the SEND inspection and also our neuro pathway, if that's okay. So yeah, for once, Sheffield's first. So if you don't mind, I'll just take the report as it is. So the first bit really is just an update on the place priorities. So I think I mentioned last time that we've now included end of life care as one of our priorities. We've now added the hospice to our partnership board, and Joe Lenton, who is the chief exec of St Luke's Hospice, is now leading this work. We think it's really important that we start to look at the number of people who aren't dying in their preferred place of death, and also there are huge inequalities that exist in this population. So we've just launched that programme last month, and I'll update you on progress as we go through the future months. Excuse me. The next item is around urgent and emergency care, and again, I think we'd say that this was celebrated, which isn't often used, in terms of the progress we've made in urgent and emergency care. So at our annual review last month, we talked about ambulance handover improvements, and at the time that we met, Sheffield Teaching Hospitals Trust had achieved a maximum handover of 45 minutes for ambulance, and they did not miss that target, which I think is absolutely fantastic in terms of where we were a couple of years ago. Also, we've made huge progress in our discharge processes with the care transfer hub, the digital discharge tool that I've talked about before, and also supporting our VCSE, expanding their support in terms of that discharge hub as well. You'll see our performance at the bottom, 13.4% of no criteria to reside in June, which again is on track to meet our target. We've got reduced admissions in quarter 1 to quarter 3. And I think, we're making significant progress. And what I like about this is that it's kind of sticking. So often we see huge variations in no criteria to reside, but I think the work we've done as a partnership with the local authority, with Sheffield City Council and with the hospital have really started to pay dividends now. So it's not just going up and down, which I think is something that we're really proud of in Sheffield. Excuse me. The National Centre for Child Health Technology, you've heard this before, but again, we've had some presentations at the board about this. This is a huge opportunity for us to really do something different with technology, also getting into our most deprived communities and making sure that we can provide different access. We know that some of the children in Sheffield don't have access to Wi-Fi and other things. So again, how can we use this as an absolutely pivotal opportunity to really start to address some of the health inequalities that exist across the city? Home care I won't touch on. Carers Week was the 9th of June to the 15th of June. Again, we provide a number of opportunities for people to come and get advice. Again, I've mentioned before, carers are absolutely crucial to the delivery of health and care, and sometimes we forget them, but they provide a fantastic role. And again, we've done a lot of support in conjunction with the local authority, again, to support carers in Sheffield. The children and young people I will spend a little bit more time on. So for those of you who don't remember, we had an inspection between the 10th and the 14th of March. on our special educational needs and disabilities work for children and the commissioning support that we offer. And for those of you who don't know, Sheffield City Council and South Yorkshire Integrated Care Board are jointly responsible for the planning and commissioning of services for children and young people with SEND in Sheffield. So we had an inspection by Ofsted and CQC, and the inspection report has now been published. It was published on the 24th of June, and it does talk about widespread and systematic failings, leading to significant concerns about the experiences and outcomes of children and young people with SEND, which is obviously really tough reading for us. I think we recognise that we would be falling short in some areas, but I would say that as a partnership, we've really tried to focus on a multi-agency programme of work over the last sort of 12 months, but unfortunately that's only starting to come to fruition now. So the inspectors recognised that we had come a long way in terms of our partnership working, but actually we hadn't been able to deliver some of those things we need to. So they identified 3 areas for priority action: the improvement in education, health and care plan content in terms of timeliness and process, the continuation of work to meet the needs of neurodivergent children and young people, and we need to continue to work at pace to improve communication, relationships and trust. So they are the 3 priority areas of action. We will now be subject to regular inspection updates from NHS England and from Ofsted just to work through how we are doing on this. There are 2 areas for improvement. One is to continue to work to ensure timely support for speech, language and communication therapy, CAMS and video fluoroscopy, and also the further development of the culture of inclusion. So again, there were some issues picked up around how we work across agencies and the culture that we need to improve on. So the city will be re-inspected within 18 months, and colleagues are currently developing the necessary action plan. So obviously been in discussions with Kathy as the lead in terms of what we need to do to make sure the ICB is delivering on the areas of priority and concern. And we are also working on a local area SEND and inclusion strategy for the next 5 to 10 years in development, with a view to that being published in September. So as I say, really tough a read. We have to do a lot more to ensure that our children and young people get exactly what they need, and we know we're falling short of that. So it is on everybody's radar and it's a key priority for us. In terms of the neurodiversity programme, again, you'll know that that has been a priority for Sheffield Place for the last 3 years. We've done a lot of work together on this, again, trying to do what we can to move this very much away from a very medical model in terms of neurodiverse children into much more of a social model. On the right there, you can see some of the things we've done. So we're a second wave pins, and people who don't know what that is, it's Partnerships for Inclusion of Neurodiversity in Schools. Excuse me. It's a national project aimed to improve support for autistic children in mainstream schools, and at the moment we've currently got 17 secondary schools, colleges involved. We've got 10 primary schools, and again it's about providing support to children and young people who are waiting for an assessment, and so that's working really well. We've had some good evaluation of that. We are working on a new pathway. We are assessing children more quickly, but it's still nowhere near where it needs to be. So there's some lot of good work going on between us, the local authority, and the Children's Hospital, and also the Parents Forum around this as well. So they are hugely involved in this, as are Learn Sheffield. So we know the only way we can do this is being properly multi-agency. No one agency can solve this alone, and we know we need to do a lot more work across the city to really get, as I say, our children and young people the right support moving forward. So sorry, that was quite a detailed summary, but happy to take questions. And at the end, we've just put some of our key achievements in Sheffield in for information. Thank you, Chair.
Thanks. Any questions for Emma? On a lighter note, I am told that some of the work you're doing in Sheffield will actually be specifically mentioned in the 10-year plan.
Great.
No, which would be good. Barnsley, Casey.
Thank you, Chair. So you'll see a range of programmes and work that we're doing across Barnsley in the update this week. I suppose just a reminder about why this is so important from a Barnsley perspective. So most recent data on health and equality for Barnsley rates us as a local authority, and out of 151 local authorities, our health inequality in Barnsley for men is 150th and for women is 151. So we have a massive health inequality problem that we have been working on collectively across health and social care for a long time. And the impact of deprivation on those health inequalities for our populations is huge. So a lot of what you see in the update today, whether it's with our hospital partners or our partners across in adult social care, is all about targeting our interventions and using the resources we've got. So we are really pleased that the Barnsley Hospital has extended its successful tobacco dependency programme into children's services for patients 12 and older. Again, hugely important for us in the sense that between people who are in our least deprived communities and people in our most deprived communities, you're 17% more likely to smoke between those communities in Barnsley. So this programme of work we are really supporting and really helpful in terms of bringing together some of the evidence and some of the brilliant work that's been happening in Sheffield from their Quit initiative into Barnsley. So some really good joined up work between places there. We've noted in here as well the Warm Homes team and the efficiency fund that's come in. This will obviously be incredibly important as we move into the colder months and ensuring that for some of our residents we are keeping them warm has a direct impact, and we see this each winter in Barnsley with the number of people who are being admitted to hospital with respiratory conditions. So hugely important link there between the work that we're doing with our hospitals and with keeping people's homes warm. Learning Disability Week was great fun across the place. I went and saw some cooking demonstrations, also had the opportunity to throw an axe. I won't tell you who at, but anyway, had an opportunity to throw an axe, which was great fun, and lots of activities for in a really inclusive way across the town centre. And then just noted, we are celebrating Barnsley libraries and museums as places of sanctuary. We're really trying, as everywhere is, to use these places as a base for service provision, whether that's for adult social care, whether that's for some of our health work, or indeed for some of the voluntary sector. And then really excitingly, the Barnsley My Card returns at the beginning of August, which offers free travel to young people between the ages of 15 to 18. And this, of course, is a hugely important part of trying to equip our children with all of the skills necessary to be able to access employment, to be able to access leisure, and also to really help ease the financial burden and pressure on families. And then just really briefly in terms of the performance of Barnsley. So you'll see noted the pressures that we have in our system around urgent emergency care, and there's a lot of work happening to try and pull together the demand management activity that's happening both in the hospital, within our community trust, SWIFT, and also within adult social care. And that is really trying to, as a whole system, look at how do we support people to stay in their own home wherever possible. Part of that is a revitalised, I would say, look at our intermediate care offer. Barnsley has the lowest number of nursed beds in independent care of any local authority in South Yorkshire, and we think that is really contributing to some of the pressures that we're seeing both at the front door and in others. So again, working collectively as a partnership, we are putting some stuff in place around that we'll both look at what we're going to do for winter and the current pressures we've got, but also look at the longer term position. And we're also working on some of our mental health challenges that we have. So what we see and understand from SWIFT is that we are consistently having more people from Barnsley in SWIFT beds, but not in the Barnsley borough. And we are working together to ensure that we understand who those people are and how we can support those people back home. We've just also noted at the end of the report the success of the respiratory programme, where we've been working with GP practices, reviewing over 1,600 patients, and that cohort is now within a managed pathway that enables us, wherever possible, to keep those people in their own homes with detailed support going out to them through the GPs and 80 practice nurses. And then just to finish, we have also been notified this week that from an adult social care perspective, we will have our CQC assessment visit first week of September. So that will be happening, and we are still awaiting our send notification. We haven't had that yet. So lots to look forward to in the autumn. That's it from me. Thanks.
Thanks, Katie. I'm not sure they're looked forward to, but noted. Any questions for Katie? Grand. Doncaster, Anthony, where are you down there?
Hello, thank you, Chair. No axe throwing in Doncaster. We're lovers, not fighters.
Oh.
Although we'll see, we actually have the CQC inspection this week over at the local authority. So there's been lots of preparation for that, and good luck to all that are involved with that. There's lots of examples in the report as ever of some of the great work that we're doing that we're proud of and will continue to do. But I wanted to use my update really to just talk a little bit about the work we're doing in Doncaster to step up to the challenge that Gavin mentioned in his update, which is how we're planning to maintain the partnership approach in Doncaster and some of the steps that we're doing at that. I've been 10 years on this journey through various guises of employment. What I've always found is a great commitment to integrated working in Doncaster, and what we must ensure is that this is not lost through the latest changes. Some of the work that we're doing with that is we had it didn't make its way into the report, but we've taken another commitment to our Health and Wellbeing Board in Doncaster. We see that very much as the future. We've got a new chair on the back of the latest local elections, but we're taking a new approach now to take our health and wellbeing boards on tour around areas of Doncaster. So in June we went to Woodlands Library with a real focus on improving the experience of ageing within Doncaster. Some of the statistics that you noted, Katie, are really sobering. It is the same, very much the same in Doncaster. We have one of the worst healthy life expectancies in the country, particularly for women in Doncaster, and that's something that we really want to address. We took our health and wellbeing on the tour to the community library, and just an example, Woodlands, to me, is a real example of what the future needs to look like. Offers a wide range of creative activity groups, digital literacy training, health checks, access to vital services such as the health bus, citizens advice, department of pensions advice, etc. And that really seems to me at the heart of what integrated neighbourhood working and neighbourhood health needs to be in the future. So it was great to see a commitment again to the Health and Wellbeing Board. The second arm of things is that I've had a lot of time with chief executives and executives across all our partnership organisations over the last couple of weeks to look at how we're going to respond to what we feel is going to be in the 10-year plan, and particularly that call to arms around neighbourhood health, and particularly that call to arms around integrated neighbourhood working. What I sense is a real commitment to that in Doncaster, and just in the report. You'll see some of those areas where we really can't lose some of the great work that we've done. So in the workforce matters area, some of the work we're doing around recruitment, retention, anti-racism, apprenticeships, etc. We can't lose that whilst we have an element of who is doing that. And I'd say the same with the digital work as well. If the theme of the 10-year plan is going to be around one of the themes is going to be around analog to digital, then some of the work that we've done around tackling digital exclusion in Doncaster puts us in a good situation for that. But again, we can't lose it as it's going forward. So we've done some great work about what the partnership looks like in the future. We'll respond to the 10-year plan accordingly. But as Gavin says, the ICB's strategic commissioning approach will be a commissioning approach with a strong partnership in Doncaster, which I'm confident we can maintain and improve.
Questions for Anthony? Chris Rotherham, please.
This has been a key challenge for, sorry, I've not put the microphone on, apologies. Someone had to do it first, didn't they? That was, I did say what could possibly go wrong. Well, I went wrong. Okay, apologies, I'll start again. So just in terms of Rotherham, reducing urgent care demand has been the key priority this year. That's from a quality, use of resources and a health inequalities perspective. Now, the good thing is, looking at Greg, sorry, but we know what the problems are. We know if we can solve respiratory, diabetes and frailty, we'll go a long way to reducing urgent care demand in Rotherham. So respiratory is picked up as an example in the report. So pulmonary rehab is particularly targeted at maintaining good health and people who've had improving health. We do have a unique asset in Rotherham. We have a place called Breathing Space, which was developed with the Coalboard Regeneration Trust, which is a breathing building which hosts specialist respiratory services. So it's maximising the benefit of that. We do come out in terms of prevalence probably the highest in the country because of the industrial heritage. You know, we have had coal and steel production all over Rotherham for many years. So looking at it positively, the opportunity is large for us. So that's the way we're approaching it. So in terms of the offering for respiratory services, we would hope we very much move into the prevention end rather than the treatment end of services. Just another one to pick up. I'll just pick up on proactive care. So proactive care is in the report as well. So this is building on case management of GPs, but this is about targeting patients. It's not universal service. It's targeting the most needy patients where we can make the biggest difference in terms of improving health and reducing the need for urgent care services. So this is GPs working with patients, working with hospital, community, mental health, social care, Shafiq's organisation, all the voluntary umbrella organisation and all the voluntary sector organisations, and having proactive care. And this is our precursor to neighbourhood work in Rotherham. It's based on primary care network footprints, which are not necessarily what you'd have. So we've 6 in Rotherham. So it'll be interesting for us, particularly when we get the 10-year plan about neighbourhood working and the definition of what a neighbourhood is, if that is indeed defined. But I feel as if the services we've put in place are very much in a precursor and can definitely flex to whatever's in that plan. So that's where we are in Rotherham, Chair. So I want to finish off. We had a SEND inspection 6 months ago and CQC are in Rotherham during July.
Chris, thank you. Yeah, I think that the NHS plan will clearly, I think neighbourhoods will be based around PCN footprint. Some of them will be too small, but I think we're all our places going to have to look at that and say, what does it mean for us? And we should know that at least tomorrow afternoon. Thank you. Can we move on to the next agenda item 12, which is performance yes, performance objectives. And who's leading me? Are you leading me through this, Gavin or Sarah?
Number of colleagues, so I'll probably look to Sarah to lead off.
Sarah.
Thanks, Chair. So just a couple of things to note before we get into the report detail. One, we have updated the report to reflect the operating guidance for 25-26. So you will see some new indicators in there, which I think is helpful. A couple of other things that need to be seen in context of performance going forward then. So we are in the process of producing a deep dive into month 2 to see where all of our organisations are against their operating plan trajectories for the first 2 months. That will go to our it will go to ODIG, which is a system-wide meeting next week. And that's really, really important to note, because if I can sense a change in NHSA, it's all about what you've put in your plan and are you delivering your plan. So regardless of whether you said you're going to underachieve the national standards, it's actually where you are against the what you've put in your plan, and we can already see some narrative playing out from NHSA. So that work's underway. The other thing that's been published in the last month is the National Performance and Assessment Framework, which again will assess organisations against a variety of indicators. The league tables, I believe, were produced yesterday. I haven't seen any detail, but that is again an indicator of how it will be going forward. From the ICB's perspective, they will not publish any indicators this year, given that we're going through changes. But we've done a very high level look through the indicators to see where we are, and I'll share those with execs first. But in future, I'll bring them to the board. So just a bit moving on. There is a bit going on in this sphere, like everything, in terms of the next steps in strategic commissioning. In terms of the IPR, I'll do the operational ones, then I'll hand over to Kathy and David and then Christine for any workforce indicators. In terms of accident and emergency then, we have seen improvement in May to 74.4% against the 4-hour standards. But actually in June this year, we've probably done the best we've ever done certainly since I've looked back in records. We're about 75% in June, which again is not quite the 78% target, but it is a significant improvement on where we've been. And I would put that down to, in the main, the fact that we've implemented the 45-minute ambulance handover in STH. So we've seen significant improvement in STH turnaround times and the whole process in A&E. It's a real positive. It does need, fingers crossed we're only 1 month in, but actually that continues. In that vein, we're implementing 45 minutes in Doncaster on the, I want to say the 17th of July, and then into Barnsley and Rotherham into August, so that we can so that we're well embedded before the winter. In terms of A&E, there is a lot of focus on winter, and we have to produce our winter plan by the end of August. We will need to test that plan early September, and there will be a national test at some point in September as well, alongside a pandemic test in September, which will make it a very interesting month in terms of that space. In terms of cancer, we still struggle with cancer. You can see from the reports there, we're not meeting the national standards, and we don't expect to this year. In terms of the real challenges, we've had a bit of a wobble in Barnsley. We've had some workforce issues that was so we get our urologists from Mid Yorks, and there's been some challenges around workforce. I expect that blip well, the blip's there. It will continue for another couple of months. We've put some additional funding in from the Cancer Alliance to put additional sessions in to clear the backlog, but that will take some months to work through the numbers. So I'm expecting that return in September to target. Biggest challenge, as we all know, is STH, and we've had that conversation here. I think the other thing, as we work more with STH and uncover more challenges, as Kirsten described the oncology challenge last time she was here, I think histopathology is also becoming an issue for STH, and our turnaround times for cancer specimens are amongst the worst in the country. We rank about 4th or 6th worst ICB, dependent on which month you look at, but we've got a real challenge in histopathology. In that vein, I have written to the histopathology to Mr. Richard Parker, who is the chair of the Histopathology Oversight Board for South Yorkshire, and asked for a formal response in terms of what are the actions that they're taking to reduce those delays in histopathology. There are some good news in the reports. I do only pick out the bad stories. You do know that, don't you? So in terms of elective then, in terms of 65 weeks, we continue to deliver that in the main with most of our providers, DBTH being the area that is struggling to reduce its backlog below 65 weeks. 2 specialties, ENT and orthopedics. There's about 120 patients in each specialty that need treatment to reduce the waiting times down. We continue in tier 1 meetings with those. We've done some specific work with around one surgeon who had a chunk of that ENT backlog. And again, we've got a solution to that, but it will take some months to work through in terms of the numbers. And orthopedics, we're doing some work looking at the prioritization even of cases that go through MEOC to see whether we can get any further utilization of that, but those 2 specialties are going to be a challenge. Looking at 65 weeks though, given the target is 65% of patients treated within 18 weeks for the end of March, we're already delivering that as a system, but we do have some challenges reducing the 52-week backlog, and that again is predominantly around DBTH. And we've put some escalation meetings in this week because as of yet, they do not have a firmed up plan on how they're going to deliver that. So we've got some real challenge there. In terms of mental health, again, there's a lot of good news stories in there in terms of those new indicators, but out of area placements continues to challenge us. And there is a working group headed up that are tackling that, but the specific area is around Sheffield Health and Social Care, where the numbers are big, and there's work going on between the council, the ICB and the trust to see how they can be reduced around that. And then in primary care, again, you can see the data there, but the biggest challenge and the biggest pressure area that we're getting from NHSC is around dental, and that push to deliver the additional 700,000 appointments across the country. And as an ICB, we haven't signed up for very good reasons because we'd already delivered additionality across the system. So that was a bit of a ramble through the IPR. I'm happy to take any questions at that point on the operational bits.
Thank you. Any questions, operational Lee? David, Lee first. Oh, okay. Lee and then Kathy. Sorry, David.
I could have raised this responding to Chris's point about the Rotherham plan for urgent care demand access and abatement. I just wanted to note the extraordinary amount of work that had gone in from the place teams, the programme teams, the PMO, about now being able to track the impact of all the work we're trying to do to decompress the urgent care pathway. If you're of the view that sustainable healthcare delivery is a bit of a function of doing something more proactive around the urgent care pathway, it's really important we can monitor that work. It's one of the issues that was identified by NHS England in their recent SIP deep dive as an area of good practice, and that has been enormously hard won in terms of trying to track the benefits associated with all the work we're doing on alternatives to conveyancing, changing our outreach model into communities. A colleague of mine, another space, Professor Samuel Gray, describes the emergency department as a failure department in a number of instances, whereby, of course, it's important you can get into an emergency department if you've had a heart attack, a stroke, or you've been involved in a road traffic accident. But the number of ED attendances is sometimes a marker of we haven't managed to intervene sooner. So I'm just extraordinarily pleased with the work we've done as an ICB in trying to enable ourselves to quantify all the work we're trying to do around left shift. And I just wanted to note that because I think that will enable elective recovery and a range of other performance metrics to be delivered.
Kathy, do you want to come in?
So it wasn't a question. I think David was kind of bringing us in for, so I'll wait. Yeah.
Let me see if there's any more questions for. Can I just add one thing, which is you talked about the league tables, and I have seen the early versions of them. Just to, I suppose I have to warn the board, these are coming out, I guess, very shortly. I don't know when they're published. I think this is the way the NHS is going to be managed by the centre. And I think people will find it very challenging to have to see those league tables. I've seen an early version. Don't know what they're going to look like eventually. This is going to be extremely challenging for the leaders of our provider organisations. But I think we ought to be clear that is the way the NHS is going to be managed centrally over the next few years. So, and I think they're currently come out quarterly, is what I was told yesterday, which I didn't realise.
So Pace, if I can check, if I can just come back on that. I had the Qs attend a regional workshop on Friday, which was about the productivity indicator that will be associated with each organisation. So something about understanding your data and what drives your productivity, and that will be published. I haven't seen an ICB one, but I've certainly seen the hospital ones, and it's quite clear that that's how organisations are going to be judged. I think my biggest area of concern of that is that we are judging the NHS against productivity that was in the early 2000s. And I have to say, having worked from a trust where we saw productivity in the NHS go to an all-time high, my worry is that in that point, having worked in a trust, if it moved, we counted it, and activity is a big driver of that. And actually, if the NHS plan gets this wrong, we'll be doing more rather than stopping stuff. And so there is a a juxtaposition there in terms of what we're being asked to do.
I agree. I think league tables are here to stay. No question about that for the next few years. I'm not sure they always encourage the right behaviour. You're right. Lee's right. I want fewer people going to A&E who are dealt with more quickly, not more people going to A&E. Got to measure the right things.
Yeah, so just two areas to sort of highlight. So I'm just going to touch on maternity just very briefly yet again. And some of my anxiety around the league tables is we'll kind of tick a box and miss the point, whereas actually the biggest way of changing the dial on maternity outcomes is the work we've already described around deprivation and population health. So whilst our numbers don't look as if they shift significantly, that's because this sort of work takes time, and I think we've already described that, and that's well understood. We do have high rate of babies that go into neonates, and that's related to all of those factors we've already described. So babies tend to be born earlier because of those complexities, but really pleased to see that actually our preterm birth rate has really started to decline. So the work that's happening in that population health space is starting to have an impact, and we've done lots of work across the system around preterm pathways and making sure that babies are delivered in women's place of choice. So seeing some significant improvement in that space. And the only other area I just wanted to touch on was around infection prevention and control. And again, I think it's quite easy, and again, this is my anxiety around league tables, to sort of get into the space that our organisations are not doing well in this space. We've seen the new objectives published in the last couple of months, and we know our organisations are already struggling to meet their C. difficile targets. But actually, if you look at the absolute improvement and reduction in C. diff cases across South Yorkshire, our trusts have done some significant work in that space, but that won't play out when we get into that sort of league table space. So I think it's just kind of having that as a note of caution. And one of the other things we will be doing is really understanding what our future role as an ICB is in that infection prevention and control space, outbreak management, and really trying to understand that as we move into the new world. And I think a good example of that, and why it's really important of partners working well together, is the recent rabies case and death that we've had in South Yorkshire, because it's always complicated in making sure that we step up and we support where vaccination's needed in a rapid space. And I think it showed some gaps in the way that we're working now. So ironing that out as we move into the new world and new way of working is going to be really important. There wasn't anything else I particularly wanted to pick out, Chair, but happy to pick up any questions.
Thanks, Cathy. Any questions for Cathy? David, do you want to add anything?
Yes, please. So I've just got a couple of additional things to add. So from a urgent emergency care, we have now received the national delivery plan. So we've reviewed that through the delivery board, and we'll implement that. There's not huge changes from what we were working on, but it's good that that's landed, so we could self-check that. We have got the national UEC team coming up at the end of the month to visit some of our A&E departments as well. So we'll welcome them and show them round. Just this week, we had confirmation of the COVID and flu immunisation schedule for this year, so that's now out. So working with Anthony and as SRO for immunisations, we'll work on that as well. I'm glad Lee pulled out about the data analytics team, because I think I chaired the population health management subgroup yesterday, and it's evident how much progress we're making. And I'm going to bring Christine in at the end of my conversation, but from being able to describe not only where the challenges are, but to be able to monitor the impacts that we're having is a really fantastic piece of work. Independent patient safety investigation, we were awaiting the publication of that from our own child death review. We're expecting that now to be mid-July, and once we've received that, I will update the quality and assurance committees, and then we'll see what we need to bring back to board. Paediatric cardiology continues to be an area that's captured in the report, but we've now completed our virtual visits of the 5 providers who weren't deemed to be low assurance, so they haven't thrown up anything. We continue to have our oversight processes with Doncaster, Bassetlaw teaching hospitals. Unfortunately, we have identified a child who has significant harm or deemed to have significant harm. It's early days for that, and we are looking at doing a deeper investigation of that, because while the trust have a part to play, we also think that the child health development should ideally have picked up things as well. But I don't have anything to respond in that. The trust have undertaken a duty of candour for all the children that have been identified within the harm review process. There is a national requirement for that to be completed by the end of September, and we are on course to achieve that for South Yorkshire. So that's reporting that to the board. I was going to bring up about population health. There's nothing specific in the report, but prompted by a couple of things that have been mentioned this morning. We have seen the announcement of availability of weight loss injections. We don't currently have that available in our primary care, but we are working on a commissioned model to be able to do that. I think I share other people's views that we're not going to medicate our way out of obesity problem within the UK, but we have seen the Secretary of State announce this week that intention to work with supermarkets to make healthy foods available and to promote them more. So I think we'd welcome that as a kind of broader response to the complex thing. So on population health, as I say, I would like to bring Christine in, because another thing that was highlighted yesterday was how we're using that approach within the health innovator. So Christine, it might be relevant if you've got some a people update as well, but let's pick that up.
Thanks, David. Thank you. So just before I do my bit, just in respect to the population health bit, in the Health and Growth Accelerator, where I'm the senior responsible officer for that programme, we are using an Eclipse tool to do a population health search of cases through GPs, and we've talked a bit about that already in different areas today. But in reporting that at a national meeting, it is clear that there are not many, if any, examples where that kind of approach has been able to successfully identify cohorts of in-work people for particular services to help people stay in work. So I just wanted to emphasise that actually the population health work that we're doing and working with Kieran and colleagues and a number of PCNs around this is actually quite innovative work and recognised as such. So the evaluation of that is going to be really key for much wider than South Yorkshire. So whilst I've got the mic, shall I just do cover on the workforce? So the workforce data in the IPR is March, so it's sort of the end of the year. And what I might observe when I do this report every month is that things don't shift a lot. So we largely remain slightly over plan on substantive workforce. We don't, we've spent too much money on banking agency, and sickness levels remain largely around the same, where every month in South Yorkshire we're 2,000 people down every month. And we've talked a lot here about health inequalities and deprivation. Our workforce have health inequalities and deprivation, and that does impact on their attendance in work. So I suppose what I'm thinking from a board perspective going forward as we go into this, how does that manifest itself? Well, it's largely manifesting itself in excessive use of contingent labour. We're in a situation where we can't increase our workforce substantively because we've got a downward pressure on growth. We've also got potential issues around cuts across the foundation trust in terms of corporate growth. And the concern there for me is different attention spent on health and well-being, retention of workforce and various other things. And those things are going to be a risk as we go into this next year. The other thing, though, is about evaluation. We do a lot of activity, and we've talked about it today, and sometimes it doesn't shift the outcomes. And so when we're looking at this data, which, on month is not really shifting the outcomes, the other thing I would say is what could we do around evaluation of what the interventions that we're putting in play and identify what are the root causes and how we can make a difference here. Because what we need is the healthiest workforce that we can possibly have. So that will help us reduce the contingent labour that is costing us too much money. And also the quality impacts of that and everything that we've talked about in terms of the place reports as a workforce element. So I just wanted to make those points, Piers, rather than just repeat the stats. That I hope that's helpful.
Christine, really helpful. Any points for Christine? Thank you for that, the performance report. Chris, the Eating Disorder Joint Committee, South Yorkshire, is that you, yeah?
It is, Chair. Thank you. So this is an area of innovation and pushing boundaries. So this is something that hopefully will have a positive impact. So what we're proposing is setting up a joint committee across South Yorkshire. It's called the South Yorkshire Eating Disorder Joint Committee. It does have a 6-letter acronym, which I won't expect people to have, but I will use that as its full name. Now, why have we picked this area? So if you were to ask the place directors, Cathy or David, where we get suboptimal solutions in a lot of our pathways is eating disorder, particularly the more complex end. And we have locally commissioned services and specialised services. And there's an area between which doesn't meet patients' needs currently. And we have quite a lot of unsatisfactory outcomes for patients. So working with the mental health, learning disability and autism collaborative providers, we picked our priorities And this has been picked as one of the key areas we can make a big difference. So we think what we need to do is we have resources and commissioning all separate. You've got NHS England, you've got ICB, you've got the providers. So we think the solution is bringing it all together in a joint committee where everyone will make strategic plans together to have one plan for South Yorkshire across commissioners. Everyone will know how the resources are spent and we can trust each other and move things around because we want to move from treatment to prevention and work through. And we've talked the ways of doing it. You can do full delegation and working through, but we've sort of come up with this, what I'd call a middle ground going through, where we're proposing that we delegate, it's in the paper, it's under section 7, exactly what I'm asking, it's underlined. I'm asking the board to delegate strategic commission decision making on eating disorders into the South Yorkshire Committee, of which it would be a member. So it would be strategic commissioning decision making on eating disorders only. I'd be the member on the committee as the executive lead for the ICB, and everyone would bring their own budgets with them rather than us delegating the budget to the committee. I could go into more detail. We have engaged Hill Dickinson, who've worked with us, and the full legal positions in there, which obviously is important. And if people wish obviously to ask questions, I'm happy to respond. So, Chair, that's what I'm asking today.
I guess my immediate reaction is it feels entirely logical. The real test for me is, can we make a difference? Everyone's identified this as a problem. I accept that. The real issue is, can we make a difference? And maybe the answer is, I'll come back to you with that, Chair, but that's the challenge. Mark.
Yeah, I was just going to add, as a provider, we're fully behind that. And I think in answer to your question, yes, we'll have to look at it in a period of time and evaluate. What we'd like to think is, without getting into too much detail, we don't think the monies that are allocated to eating disorders are spent as effectively as they could do at the moment. We talk about, I guess, inequalities and levelling up. What we see at the moment is very significant differentials between the service provision in each of the 4 places. So this would theoretically, if we can actually get the monies right and invested in the right pathways, would be an opportunity to level up as opposed to actually have these significant differences. And what we'd also say, I think Chris alluded to earlier, was this could easily be a pilot for the service in the future. It's not a particularly huge service, so if it works well for this, it could be a test case for other services in the future.
Kathy, I think.
Yeah, and thanks, Chris. Really helpful. I suppose my question is, so you kind of focused on budgets. There's a lot of talk about kind of finance and productivity in the paper. I'd just like to be assured from where the quality, safety and experience voice is going to sit in that committee, and how we're going to make sure that that's heard, because there's something about financially well run commissioning, but actually is that improving outcomes, and is it a quality service, and that can mean very different things to service users.
So in the paper, we're not proposing any changes to the current quality arrangements. That's not part of what we're proposing here. So we would maintain, we think the strong arrangements currently, we would propose they're maintained in their current form.
Just check quickly. Broadly agree. Just kind of testing the downside, the sort of atomization. How granular do you go? Do you have the ingrowing toenail survey, all that kind of stuff? Mark, I get your point on the underinvestment. I agree 100%. It's a big opportunity, but who loses if we invest more in X and not Y? Who loses? What's the broad process for that? I'd be in the sort of space of yes, but test and learn for a period, and then evaluate, see how that goes.
Look, I'm sure that's right, and I think I would like for us to come back and say, well, what's the first 6 months look like? What have we learned?
Thank you, Chair. From the outset, I fully support this as a way forward. I think the strength of it will be the coalition of the willing going forward, and we shouldn't undersize that in terms of its impact. Note, and it's already been commented upon, this is a pathway experiment. We have to be comfortable with that. I am. I think because this, as Mark has indicated, this could give us the bones of model of commissioning for the way forward. So I think it really would be interesting to learn and understand that. Having said that, there are some issues that we need to test. And one of the things that I would just need to understand is, does this in any way compromise us as a commissioner in terms of our responsibilities for the provider selection regime? and what would the workarounds be if need be. And of course, in delegating responsibility, we still hold responsibility locally. What would its reporting arrangements be back into the ICB? So with those two caveats and levels of interest, I think we should fully support this.
Just to respond immediately to Kevin on provider selection regime, I think we're content, Kevin, that we've got the coalition of the willing all engaged in this. I think we're fine on the provider selection regime side, but it is a bit of a test case around just the candidly a slightly interesting. To what extent are we backing a competitive model or we're backing a collaborative model about how we reconfigure these services? But I'm entirely persuaded, actually, that the way we will deliver less fragmented, better clinically effective care for this cohort of patients is trying to get the provider side to work out how candidly we can move away from a model that kind of rescues at the last minute, candidly in quite a cruel way for families. So this is a hugely contested area. It's going to be really difficult. I think the quality oversight is going to be really important and hard, but I'm entirely persuaded the only way we're going to solve this is getting that constituency they're willing together and going, how can we do something more proactive and upstream as opposed to leaving folk to the last minute in a care model that I might regard actually as being quite cruel.
So if you remember a couple of months ago, we did actually have a patient story on this, and I think this does respond to the things we heard. So that's the first thing to say. I think the second thing is that actually over the last couple of years, there's been a number of clinical summits which I've attended myself. So the clinicians were bought into, we needed to do something different. It came on the back of, through COVID, for one reason or another, we saw a huge increase in the number of people who presented, young people particularly, and at the severe end as well. So, things changed and impacted on people. This was one of the things that came to light. So I must admit, I'm fully behind it. Thank you.
Yeah, definitely fully behind this, because I think this pathway has a potential to really underserve this population. I think my only observation is on the committee, do you have experts by experience or that patient involvement while you're shaping this new pathway?
No, that's a fair question, Lisa. At the moment, the committee is actually a couple of chief execs and chief operating officers. I'll take that back because I think that's a very valid point.
Thank you. Board happy to support that? Yeah. Grand. I do think Kevin's point is, I think this is something that might give us a way of doing a lot of work in the future. So we should take real interest in it. Okay, that's the end of that agenda item. Right, I will now give you a 10-minute break back here at 14:15. Agenda item 14, annual accounts and annual report. Lee, is that you and Mark? Yep. Grand.
I'll start, Chair, and then Mark can potentially contribute. Very pleased to report we've completed the external audit of our statutory annual accounts and report. Nothing has deviated from a finance perspective in terms of findings by the external auditors. So, as already reported to board, the ICB made a deficit of 38.3 million at the year end. To be honest, in terms of how the statutory accounts and reports for the ICB are laid out, you probably need to be a forensic accountant to find that number on page 256. But it is there, but it's hardly laid bare. It's worth just reinforcing that is the wrong number, to the tune of 38.3 million in terms of what we're charged with in terms of our statutory duty to break even. From a system perspective, that was compensated for by a deficit in our provider organisations, but from an NHS England perspective, in terms of building confidence about our ability around financial delivery, obviously if in 24-25 we delivered net a £30 million deficit and we've got an enormously challenging plan this year, that's the context we're operating in terms of making sure we can do all we can around delivery of financial performance. But exceptionally pleased to report, Chair, a very good external audit process working with our colleagues in KPMG. No significant findings through audit committee to my eyes, but Kevin may want to corroborate that from a chair of audit perspective. But congratulations to all the team who've contributed to the annual accounts and annual report process, but Mark may want to comment a little bit more in the annual reporting space.
Go over to cabinet and the account.
Thank you, Chair. I can corroborate that our auditors reported a very clean set of accounts, which is noteworthy for all of those involved. Clearly, the failure to break even has resulted in a statutory but normal referral upstairs, and so I can corroborate what Lee has indicated. Thank you.
Your report.
Yeah, Chair, just a couple of things to add to these what Lee's just said. Equivalently, the annual report has been subject to external audit review. The annual report includes our annual accountability statement and the governance statement. It also includes the head of internal audit opinion, which this year, I think quite notably, it is significant assurance, which was a kind of the testament to a lot of work across the organisation. So I would kind of recognise that and thank the colleagues across the organisation for that. As has already been indicated, the Audit and Risk Committee met on the 17th of June to complete the final review with both internal and external auditors present, offering their scrutiny also. And then the delegated subcommittee of the board met later that afternoon on the 17th to approve the signing of the annual accounts and the submission of the annual report to NHS England. So it's presented today for approval.
Thank you. Okay, people happy you approve it? Yeah. Grand, thank you. 15, the financial delivery report. Lee, I assume.
The report in front of you describes where we're at both as an ICB and as an ICS in terms of month 2. So Gavin's already started to describe this really in terms of off-plan performance and just the seriousness of that. It's probably worth putting that into a broader UK PLC context. In my sort of health service finance career, I've never really had national NHS finance briefings that have kind of started with UK PLC context, but that's largely where they start now. They start with you are a large government spending department, we have a big fiscal challenge and we need to invest more in defence, is kind of how the kind of NHS finance briefings now start at a national level. So I think there is something about this large spending department that we've got and just ensuring from a governmental perspective it's living within its means. So I think there feels like there's a lot of heightened scrutiny at the moment on NHS financial performance in a way that probably there hasn't been actually in my whole NHS career. And I think that's down to the larger fiscal climate that we're operating in. So that's very broad context. If we now anchor that right the way down to what's going on in South Yorkshire, we were indeed off plan in terms of the month 2 position. Just in terms of the phased plan, it's often the way that we start off with a deficit in the year and then we sort of gather savings as we go through. So at this stage in the year, from an ICS perspective, we planned to have a £13.6 million deficit. We actually had a we had a planned deficit of 10.7. The actual deficit was 13.6 million. So we're off plan as an ICFs. From an ICB perspective, we've got a year-to-date variance of 3.5 million versus a plan of 2.7 million. So both in the wrong direction, hence the need for further work around how we're going to deliver our large and expansive savings plan, which we'll talk about outside the board meeting about that subcommittee of the board. That there are 2 particular variances in the year-to-date position that I've identified from an ICB perspective. One relates to an overspend around ASD and ADHD and right to choose. So there's a schematic in there that just explains we might not have been able to see that coming in terms of the additional cost burden of right to choose for ASD and ADHD. And we're currently looking at, can we course correct for that in terms of who's accessing those services and is it all clinically appropriate? So we're looking at how we can potentially contain and correct that spend. And the other area of overspend relates to CHC, where we're doing some detailed work just to understand the market management, price and volume variances. At this point, Kathy would remind me, and it's true, we absolutely have a statutory duty to deliver those services, and if we're delivering them within statute, they may or may not overspend. But there's some further work we can probably do around market management and just making sure there's much as we can do. Now, the reason why I raised those 2 issues, particularly in the finance report, is if we're going to deliver break even, we've got to sort out those two issues as well as delivering our over £90 million savings plan. So any variances that we get in year, we've got to course correct for those things as well as delivering a large savings programme. So I welcome the opportunity to have a subcommittee of the board to talk about how we're dispensing our responsibilities around financial savings and delivering that with a little bit more focus, because I think it's going to become desperately important for the ICB standing through this year for those bigger reasons I identify around UK PLC. So we're not off plan enormously, but I think there's going to be an enormous amount of scrutiny about each ICB and each ICS's finance position. So it's entirely right that we're giving it a little bit more scrutiny through the subcommittee of the board we're proposing. Happy to finish there, Chair, but very happy to take some questions.
Kathy.
Yeah, and I think it's just to kind of support Lee in that space. I know I remind you of it, Lee, but I'm also very conscious that we've got efficiencies to deliver as well. And there is some there's a national CHC model group been set up as part of the kind of ICB footprint work, and my understanding is the focus on that is to try and get some best practice shared around how we improve the efficiency of care whilst maintaining the quality and meeting our statutory comments. And it's a cross-sector group, so it's not just health, it's got social care representatives. So as anything comes out of that, we'll make sure that that's fed into our programme as we go forward.
Can I just add something on the turnaround? We will be setting up a turnaround group. I will chair that, and I've asked Kevin and Moira to join me as chairs of the relevant subcommittees, and in a sense it's about satisfying ourselves that we've got the money in order, that we have plans that make sense, because Lee's right, we should be under no illusions. The pressure to deliver the financial targets we've been set are growing more intense by the day, not just on us, by the way, but on our providers. But I'm particularly concerned about us, and that's what that group is. We will work out setting up a timetable for the meetings over the next week or so. Mark and I and Gavin are talking through that. But that is meant to satisfy ourselves. I think the non-execs need to be entirely satisfied we've done everything, and that's what that's about.
Thank you, Chair. I mean, yeah, just to reiterate the point that although the off plan seems relatively small at the moment, we need to keep a really tight eye on it. And as non-execs, to support executives and also seek that assurance that we need, and as does NHS England need, that we're doing the best we possibly can in a challenging situation. And we're also, I think this. Obviously, the ICB, we need to make sure that we meet our spending efficiencies, but we also need to continue to work whole system. So, I'm meeting with the other non-exec finance leads in the trusts as well to make sure that we're all aware of the whole picture and how we can work together on it.
Kevin.
Thank you, Chair. I think there's not a question of detail, because clearly that will be a function of the committee that you're going to establish. But this is now a sort of a focus on our firepower as an organisation, because there's a shed load of work that needs to be done, and for reasons that Gavin and others have explained during the meeting, it's a very disrupted year for us and our people. So there's something we need to think through about how do we not only maintain our firepower but increase the firepower. Within that, it's how do we, with all other things that are a priority for us, maintain the focus. But perhaps a question around some of our processes as well. So we've talked about the PMO. I'm pleased to see that. I think what I heard was, I think Sarah's been lined up to oversee that. That needs to be a really quite disciplined approach. But the bit that perhaps we need to reflect upon is, and again, building on Gavin's earlier question about SEB, some of our savings plans at the moment are parked under that process. So we do need a very clear line of sight from a governance perspective, from a PMO perspective, into being satisfied that they are being delivered by something that's external to the ICB. But I just think it's something that we do have to work through. So I think there's a lot of things to set up, not least of which, delivering the savings.
Great, and we'll set up a timetable and get in touch with you over the next week or so for a series of dates as to what we're going to do. Any other questions for Lee on the finance? Thank you, Lee. Corporate insurance report. Mark.
Thanks, Chair. There's too many buttons on these microphones, but anyway. I will be brief, but I will just highlight 5 items from the papers. So, taking the report as read, ask the board to note the corporate activities that are set out, including the regular publication of our probity registers on the internet. Secondly, I just bring to the attention of the board for ratification. There are a number of items that have been through due process within the organisation and have been approved by the executive committee of the board. So they are the business continuity policy and response plan, health and safety policy, and the standards of business conduct policy. So they're presented to the board for ratification. There are 3 items for board approval in accordance with the scheme of reservation and delegation. One is the updated and reviewed terms of reference for the formal executive group. The second is the ICB transition committee, which has been stood up to support oversight by the board of the transitional arrangements within the organisation subsequent to the implementation of the organisational change plan. And thirdly, there is an updated procurement policy for approval. Excuse me. Final items, just noting the latency. I would just wish to note that NHS England has approved the amended constitution that was approved by this board some months ago. So that's now extant and is published on our internet and intranet as our standing constitution. And finally, and I don't know if David wanted to pick this one up, there's work underway with the ICP around a memorandum of understanding.
So that's with Sport England, the integrated, the Simca and ourselves who met with Yorkshire Sport and the development of an MOU we hope to bring to the next meeting. So we're just highlighting that will progress this month and we'll bring that to a future meeting. Thank you.
David, thank you. Can I just add something else? Probably ought to be formally noted. Clearly, we're going through a period of major change around the ICB. On that basis, what we have done, what I have done, is renewed the contracts of all non-execs and partner members to the end of March. And the idea of that is to allow us to function as a board over the next 6 months. It is expected, I think, 9 months. It is expected, I think, that the ICB come the 1st of April will be dramatically different in size and scale, and we'll need to manage that. What I've done is put us in a position where we can stay ultra vires and make likely to be a series of difficult decisions ahead of that period. But I think I've told you all individually about that. Okay, thank you for that. Integrated care system green plan. David.
Yeah. So I bring the paper today and present it to you, the South Yorkshire's Integrated Care Sustainability and Green Plan for the next 3 years. It's been developed in collaboration with our provider trusts and incorporates the ICB and the ICP strategic priorities. This is the second plan that we've had in existence, and it helps us meet our national net zero policy guidance and also our statutory duties within the Health and Care Act and the Climate Act 2028. I'm not going to go through in great detail, but would like to pull out a few key elements, if I may. I mean, the World Health Authority claims that climate change is the biggest threat to our humanity. It's been reported today that June was the hottest period in record, and temperatures, not only here in the UK but across Europe are 40 degrees. We can't but note that there is a significant change in our climate, and greenhouse gases are linked to have some impact on that. The health service is a significant contributor, representing about 4% of carbon emissions on there. So I think we've picked up today about the strong associations between population health, health inequalities and the climate as well, because unfortunately it's another example where people from our most deprived communities are also affected the most by this. Over the last 3 years, you'll see within the document, we've got a number of programmes of work where we've made some inroads. Within medicines, we've looked at waste reduction of medicines with use of our inhalers, and also the decommissioning of some of our more pollutant anaesthetic gases. In our estates, we've managed to be successful in our bids for LED lighting within the acute trust. Actually, as an ICB, we've moved offices as well into more economically and environmentally friendly buildings. Schemes like travel with our e-bikes and provision to general practice, STH, have a loan e-bike process, and actually some of our HR processes where we allow a lease car scheme, but only for EV vehicles. And finally, you know, how we work together, our change, you know, COVID has really promoted this hybrid working, remote consultations, and really the use of innovation technology. I think the key bit I'd like to pull out is how we've embedded this as an ICB, and I think we've been quite unique in our quality health impact assessment by not only looking at quality elements, not only looking at you know, population health, but having a tab that considers sustainability in all our programs that we review. Of course, the benefits for this are not just on our health and our populations, but actually financially, there's often a benefit for us from efficiencies by using things more, you know, kind of, you know, mindfully. I'm also the exec sponsor of our Green Staffer Network, and it's nice that we have so many champions within our organisation that help us as an organisation, as anchor institution, make the most of those. So in summary, I bring the Integrated Care Board, you know, the plan that we need to submit to NHS England by the end of this month. I'm happy to take any questions, but I hope people can commit to it so we embed it into our ongoing planning, commissioning and assurance activity. Thank you.
David, thank you. Any questions? Greg?
Cheers. David, I agree with you. Biggest public health crisis in the next 200 years or so. Show me a bigger one. Just 4 thoughts as I read it. One is the sort of how happy are you with the fit with the 4 place-based pushes on net zero, climate adaptation, etc. And there's a sort of just an orchestration thing to think through. It doesn't sort of talk much about overdiagnosis and overtreatment as carbon emissions, and probably should talk more strongly to that. And it didn't talk strongly enough around, to me, around extreme heat and response. Who is going to look in on Mrs. Smith at number 44 when it's going to be 42 degrees for 14 days running, etc. And ditto vector-borne diseases. You know, the dengue is already in Paris. There's a perfect vector to get it to London. It's called the Eurostar. We're not ready. So there's something to think through in the medium term on that.
If it could just respond back to that, because obviously this request or this requirement to submit this plan predated the ICB blueprint document. And actually is stated within there that, you know, our responsibilities as strategic lead for this may change going forward, and it will be up to individual organisations. So I'm conscious I've brought this at a point in time where things are changing around us, but I think we can't negate the responsibilities of the elements that we have as a board and as an NHS. So I'll make a note of those, and I think we just accept those. Thank you.
Thank you, Greg. Any other points? David, thank you. Right, we then have a series of items for information. Did you get that? They're for information. That's not to say you can't raise a point. System leaders, place committee and the assurance committees. Anyone would pick up anything from those? Grand. Okay. That's the formal end of the meeting. Is the next meeting here in Broad Street as well?
It is,
yeah. Okay. Next meeting, formal meeting on the 3rd of September.